Thank you so much, Dr. Blanco, and I want to just extend my thanks to the cooperative group for the opportunity to be with you here today and talk about thrombosis and reducing the impact. I want to thank Dr. Blanco for her participation on our steering committee. I want to thank Dr. Casais for her leadership in so much of World Thrombosis Day activities and efforts to impact thrombosis. And I want to say that I want to thank all of you and commend all of you in Argentina for your leadership, because I think you have stepped up and taken activities that are just remarkable and are an example and are really exciting to see. So thank you very much. I do want to give you my disclosures. I do have a lot of relationships with various companies related to research in this area. I thought what I would do in the time that I spend with you is talk a little bit about the role of thrombosis in the global burden of non-communicable disease, particularly as we see global health evolving for many developing countries, moving away from infectious disease as a major cause of morbidity and mortality to non-communicable diseases, cardiovascular disease, and underlying mechanisms of thrombosis is becoming more and more critical. And then talk just a little bit about two areas, venous thromboembolism, of course, but also a little bit about the impact of atrial fibrillation and its efforts on thrombosis. And then spend some time discussing strategies for reducing the burden from thrombosis, particularly focused on venous thromboembolic disease and reducing its impact. So it may surprise some of you to know that if we take into consideration acute coronary syndromes, ischemic heart disease, thromboembolic stroke, and pulmonary embolism, that the underlying mechanism of thrombosis, which is the basis for those conditions, is responsible for 1 in 4 deaths throughout the world. And this is really quite remarkable when you think of this. And so clearly what we're saying to the World Health Assembly and to the World Health Organization, that if you want to achieve the goal of reducing cardiovascular deaths and non-communicable disease by 25% by 2025, we must make a major effort on thrombosis. And these are the data from the Global Burden of Disease study, which is coordinated on behalf of both the World Health Organization and the World Bank to evaluate the causes of death, more than 200 causes of death across more than 80 countries as assessed by the World Bank to be in categories of low, middle, or high income. And the latest version of this study in 2010 reported that there were 52 million deaths in the world. 34.5 million, or 65% of those deaths were due to non-communicable causes. So now the majority of deaths in the world are non-infectious causes. And ischemic heart disease, 7 million, ischemic stroke, about 2.8 million, and the amount of venous thromboembolism was not assessed. What we're seeing is, as developing countries do a better job of treating and controlling high blood pressure, the balance between hemorrhagic strokes and thrombotic strokes is shifting. And so when we take better control of blood pressure in developing countries, typically about half of the strokes are thromboembolic and half are bleeding. But as we do a better job on blood pressure, we move to what more developed countries now see, which is about 85% of strokes being due to thromboembolism. And so it's very clear that in order to make a large global impact in reducing premature death and disability, we have to address thrombosis. I'll have a couple slides about atrial fibrillation, because the ISTH really, when they began thinking about World Thrombosis Day, really made a commitment that we were going to represent and deal with all of thrombosis, and to impact that 1 in 4, we have to do that. Because there was already a World Heart Day and a World Stroke Day, we decided to focus initially on venous thromboembolism, but as time progresses, we're also going to begin to come into areas of arterial thrombosis as well. We have to if we're going to change that 1 in 4 deaths. And I've chose atrial fibrillation because many of the principles are the same as what we're then going to go into more detail on in venous thromboembolism. So here you see in 2010, again from just this last fall, data from the Global Burden of Disease trial study, that about 33 million people globally have atrial fibrillation, and that we're approaching almost 5 million new cases every year. And again, as we do a better job of reducing death from coronary heart disease through prevention, through lifestyle modification, through statin treatment, through blood pressure control, through all the appropriate steps we're taking, more and more patients are living longer with chronic cardiac disease, and then they're developing atrial fibrillation. And while the age-adjusted incidence for over age 35 is shown in the slide, about 1.8 men and 1.4 per thousand people, what we know about this condition is marked dependence on age, and that there's a high regional variation and a very strong impact of age. So if we look at North America, for example, which is leading the situation in terms of atrial fibrillation, we see that the incidence goes from 2.4 in people 50 to 54 years of age in men to up to more than 45 per thousand men in above age 80. Whereas in Asia Pacific, it's lower, but there is still a significant age dependence. And so the burden will still be large as we see an increasing amount of the population moving into years 80s. And it may surprise you to know, for example, that Hong Kong, for example, has the 4th highest life expectancy in the world. And so Asia, although the incidence is lower, will also have a major burden. Here in Argentina, I think you will be progressing very clearly on the same path to what North America has with respect to the impact of atrial fibrillation. And it's estimated, for example, that 10% of men 80 years or more, or 5% of women will have atrial fibrillation in North America and Europe, a lifetime risk of 1 in 5 men developing this. And the impact, the disability adjusted life years, are what we call the DALY, which is really the sum of years of life lost prematurely or years lived with a disability, in this case stroke due to atrial fibrillation, has markedly increased since the early 90s. The mortality has doubled. And even as recent as last fall, when the Oxford Shear groups published the OXVASC study, this is the key parallel: 44% of the disabling strokes were AF related. And the first time that the person was discovered to have atrial fibrillation was when they came in with a stroke. And keep that in mind, because it's a general principle that we also know about venous thromboembolism. So if we turn now to venous thromboembolism, we know from our systematic review of the literature on the disease burden that there's about 1 to 3 cases per thousand population, but this increases very significantly according to age. The CDC in the United States documented more than 500,000 hospitalizations due to venous thromboembolism in 2007, each year in 2007 to 2009. The estimated number of cases are listed. The data from the European Union is more than 500,000 deaths, and this is very good epidemiologic data from Professor Cohen. And the WHO has conducted a study through their patient safety program to evaluate the adverse consequences of hospitalization in 7-8 causes, such as hospital-acquired pneumonia, catheter-related bloodstream infections, other complications that occur in hospital. They found that venous thromboembolism was the leading cause of death and disability associated with a hospital stay in low and middle income countries, and the second leading cause in developed countries, according to the definitions used by the World Bank. So this cuts across the entire spectrum of countries represented in the WHO and is clearly a critical problem. Now, with regard to non-fatal cases, there is a very significant morbidity and disability that is contributed to by venous thromboembolism. Pulmonary embolism, non-fatal pulmonary embolism, comprises about 40% of the non-fatal cases, and increasingly we're learning that a significant number of those patients, perhaps about 4 to 5% within 2 years or so, develop chronic thromboembolic pulmonary hypertension, which can be a very significantly debilitating condition. Regarding deep vein thrombosis, a greater proportion, probably 20 to 30%, by 2 to 5 years will develop very significant, moderate to severe post-thrombotic symptoms in the leg, which is pain and swelling when the leg is in a dependent position, which impairs people's daily activities and also, for some patients, impairs their ability to work. So when we think about the impact of venous thromboembolism, about 2/3 of its impact is due to premature death. I'm going to come back to that in a minute. And then about 1/3 of its impact is due to chronic disability created by people who survive and live with this condition. And the key point, of course, is that just like we saw with atrial fibrillation, where the presentation of stroke is the first time that someone finds atrial fibrillation in a patient, often the initial presenting symptom of venous thromboembolism is sudden death, which is therefore why prevention is crucial. And so we have to keep that in mind, and that's really part of our thinking with respect to both the current focus of World Thrombosis Day going forward, but also some of the new cutting-edge research that I'll mention a little bit later on. So if we summarize the disease burden from thrombosis, the mechanism, is responsible for 1 in 4 deaths globally. I think that fact is something we want to get much more awareness of and talk about more, because we have been, as a group, as a thrombosis community or a hemostasis and thrombosis community, too quiet about emphasizing the importance of this pathology. And we've actually, as you saw from the awareness, siloed these conditions into different things: heart attack, stroke, so on, when in fact there is a commonality in the mechanism. Atrial fibrillation and venous thromboembolism are major contributors to this global burden, in addition to acute coronary heart disease. The age dependence is striking in terms of its impact on incidence and prevalence, and so as we do a better job of keeping people alive and people living longer, we want to be sure that we're doing all we can to prevent these conditions which badly impair their quality of life or lead to premature death. Venous thromboembolism associated with hospital, as I mentioned, was a leading cause of disability-adjusted life years lost across these countries, across the spectrum of countries in the world. And prevention is the key to reducing premature death and disability from both of these conditions. This was shown by Dr. Casais. If we look globally at the situation, we just remind that I think the reason that many more people are aware globally of these common conditions, including breast cancer, for example, and AIDS, is that for many years those conditions have had communities organize around those conditions and have global public awareness campaigns to make people aware about that. And we in the thrombosis community, thrombosis and hemostasis community, have been rather quiet, particularly with respect to venous thromboembolism. Of course, people know about heart attack, people know about stroke because there are heart associations, there are advocacy campaigns for those conditions, large campaigns for cholesterol, for example, and so forth. But we have been very quiet, and no one has stepped up to take ownership of venous thromboembolism. And I think part of that is because it cuts across so many medical specialties and scientific disciplines, that cardiology, pulmonology, hematology, general internal medicine, no one said, we're going to make an effort and take this on. And I think finally now the ISTH has said we need to do this, and I think that's going to be our focus. And we need to do that, as you saw. And people don't know the risk factors. So I agree 100% with the comments that were made, which is we are not about creating alarm or inappropriate concern amongst patients, but we want patients to be educated and aware. And my colleagues say so much, that patients who come into the doctor now have so much information off the internet. So that effort is occurred. We're not going to be able to change that. But what we can do is we can impact that by saying, let's be sure that the information those patients is coming in with is accurate and appropriate information, because so much of what they get off the internet is nonsense information. And so what we want to do is create educated patients. And when patients are educated, then I think they can engage with their physician in an informed conversation and be part of the shared decision making about their care and what they want for themselves in going forward. And you see here that only 25% of people knew that being admitted to a hospital was a risk factor for developing venous thromboembolism. Few people know that having surgery can be a risk factor. So if we look at hospital-associated venous thromboembolism, that single thing, being admitted to a hospital within the previous 3 months, accounts for about 60% of the entire disease burden of venous thromboembolism. And so this is a great place to begin to affect, because in fact this is where we also have a preventable condition. And as you saw, the majority of people didn't know that this condition is preventable. And so I think that these points allow us actionable messages and communication to the public. The risk period often extends beyond the hospitalization because hospital stays have become shorter for various medical or surgical conditions. But the admission to a hospital is an ideal point at which we can begin to engage with patients with preventive strategies, which may then extend beyond the hospital stay, or they may not, but at least it's an access point at which we can engage prevention. And you may know that of all the fatal pulmonary emboli, most of those occur in the medical patients admitted to hospital, not in the surgical patients. So about 3/4 of the fatal pulmonary emboli, from the best we know from older autopsy studies, that patients admitted to a medical ward with heart failure or chronic pulmonary disease or acute pneumonia or other acute medical conditions, they comprise about 3/4 of the deaths from pulmonary embolism. The surgical population is 25%. If we look at surgery and where we are with major orthopedic surgery, we're really actually doing quite a good job of thrombosis prevention in that population. We can argue with the orthopedists about whether they should use anticoagulants or aspirin, particularly probably American argument, but around the world, I think whether they should use low molecular weight heparin or newer anticoagulants or how long they should give, those are details for healthcare professionals, of course, which are relatively minor in the context of the fact that almost everybody is getting something, in orthopedics at least. But on the medical side and on certain other conditions, when we do global audits of prophylaxis, we find that we are not implementing the evidence even as healthcare professionals as well. And the medical population is a key population. And with that and with the knowledge of hospital-associated venous thromboembolism, the recent guidelines have said for the non-surgical populations that the shift now is towards an individualized risk assessment approach in patients. And this fits then into what our messages are going to be with World Thrombosis Day. And in fact, as a committee, steering committee, one of our principles from the beginning was we were never going to advocate to the public for things that are not evidence-based. We must stay evidence-based in order to have credibility as clinical scientists and researchers. And but knowing your risk and engaging with your healthcare provider for a risk assessment fits entirely with the current evidence and recommendations by evidence-based guidelines. This is one of the recent guidelines. There are many others. So this year, and as was mentioned, this year and for the next 2 to 3 years, more than now 200 partners globally who have joined in will focus on the issue of, if you're admitted to hospital, ask your healthcare provider about your risk of venous thromboembolism, ask for a risk assessment, be sure that you have a risk assessment, and that risk assessment would then be linked to, if you're assessed to be high risk or appropriate risk, then having some preventive measure. We're not trying to dictate to physicians or other individuals what they should do in terms of prevention, but we are simply saying people should have a risk assessment. Some of those patients will be low risk and nothing more will be needed, and that's appropriate. But by educating the public, I think we'll help ensure that this issue gets addressed when the patient is admitted to the hospital. And that's key, I think, to reducing death and disability from this across the world. Now, the last 2 days, I've had a wonderful time here in Argentina, and we were working with all of the participating Latin American countries in this study, which I think will be an important study potentially to advance the cause, and that is the Mariner trial. And I want to recognize and thank Dr. Casais for her leadership as a national lead investigator for Argentina. The Mariner study is really addressing an unanswered question, which is, in that population of patients who are admitted to hospital for medical reasons, they have received prevention during the hospital stay, is there a benefit of continuing anticoagulant prophylaxis as an outpatient for 45 days? Because the lengths of stays for many conditions now are shorter, patients are leaving, but they continue at risk for venous thromboembolism. And so this is a randomized trial in 8,000 patients across the world to test whether an appropriate dose of the direct oral anticoagulant rivaroxaban will prevent symptomatic venous thromboembolism and fatal pulmonary embolism in these patients. And the impact could be profound if we can make a reduction of perhaps 1% in the number of venous thromboembolic cases. We could reduce by 40% the number of cases throughout the world. We could save many thousands of lives. And so this trial is just getting underway and will take a while, but we hope we will enroll 8,000 patients to test this in a very rigorous study. And this could be an advance because, of course, the advance is we now have a simple medication, the new oral anticoagulants, which are easier to use than the injectable medications, heparin, low molecular weight heparin, or the vitamin K antagonists, which require monitoring and dose adjustment. We can also reduce the burden from venous thromboembolism with certain aspects of treatment. For many years, this is the scheme of treatment. Patients with venous thromboembolism receive acute initial treatment for 5 to 10 days. They then have some oral anticoagulation for 3 to 6 months. And then we think about extended treatment as being more than 6 months. And historically, we have many options, of course, for the acute treatment. We have heparin and thrombolysis and a number of other options. Anticoagulation is the approach of choice for the vast majority of patients. But what you see historically was, as we moved out in time, and certainly beyond 3 months, which is the minimum duration of treatment for all patients, we had very few options to treat other than vitamin K antagonists. And because of the risk of bleeding and the burden of treatment, the complexity of treatment, the drug interactions, the burden it places on patients to go for their monitoring, the challenges it places on physicians for adjusting the medication, vitamin K antagonists were by no means an optimal approach for long-term treatment to prevent recurrent thrombosis. And so many patients would, either because of their desire or because of the physician's uncertainty about the risk-benefit or the complexity of treatment, would not go on to extended treatment. And now that we have newer oral anticoagulants which can be given as a single or twice daily dose without monitoring and are easy to use, that we have now an option for the longer extended treatment of the patients for whom this may be appropriate. But what's been the real game changer has been the observation in the studies that these agents are also safer in terms of reducing the risk of bleeding. And so I want to show you some of that evidence. Of course, we also now have evidence that aspirin may be an option also for long-term treatment, so a very inexpensive, simple medication which may have the potential to reduce recurrent events. So here we're talking about a patient survives an event, but if we can reduce their recurrent events, we can impact death and disability as well. So there have now been many trials, several trials in more than 25,000 patients with venous thromboembolism that compared the risk and benefit of the direct oral anticoagulants that either inhibit factor 10 or, apologize, this went forward, that either inhibit factor 10 or thrombin by comparison to the vitamin K antagonists. And what we find is very strong evidence that the newer agents are as effective as vitamin K antagonists, but they are safer. The risk of major bleeding is reduced, so that with every 150 patients who we would treat with these new agents instead of vitamin K antagonists, we would avoid a major bleed. The risk of intracranial bleeding is reduced by 2/3, and the risk of fatal bleeding is reduced by half. And so while these number needed to treat for the individual patient may not seem very small, nevertheless, when we know the large number of patients with thrombosis who are going to be treated, if we can prevent intracranial really serious bleeding, fatal bleeding, major bleeding, we have a safer therapy. We shift the balance of risk-benefit towards the potential then for more longer treatment. And that's really what this next slide talks about, the patients with unprovoked thrombosis. Those are the people who come spontaneously. They don't have identifiable risk factors. What can we do to reduce the burden of disease? We know that we must treat them all for 3 months, and all physicians are pretty comfortable with doing that. But at 3 months, we have to then ask the question, what are our options? We can stop treatment in everybody. That doesn't seem to be the best. We can continue treatment in everybody. That may or may not be the best. We can use aspirin, or we can identify selected patients at low risk to stop anticoagulation. Increasingly, we're learning most of these patients are not at low risk. The unprovoked population has quite a high annual rate of recurrent venous thromboembolism, whether you stop treatment at 3 months, 6 months, 1 year, or 2 years. So we need something. And historically, physicians have been picking and choosing because, again, of the undesirability of vitamin K antagonists. And there have now been studies that have looked at extended treatment of these patients with the new oral anticoagulants, the direct oral anticoagulants. And I'm just going to show you one of those, and that was the Amplify extension study with the agent apixaban. And so this study enrolled a large number of patients who had a deep vein thrombosis or pulmonary embolism, and then who received 6 to 12 months of anticoagulation. And now the question was, should I continue or not? And they were randomly assigned to either placebo or 2 doses of apixaban, either 2.5 milligrams twice a day or 5 milligrams twice a day, and they were treated for 12 months. And what you see here is that the the risk of recurrent thromboembolism over that 12 months. Remember now, in people who had already been treated 6 to 12 months and now were stopped, over that 12 months there was about an 8% rate of recurrent venous thromboembolism if you stopped anticoagulation, and that was significantly reduced down to under 2% by both of the regimens of apixaban, with the number needed to treat, meaning that every 14 patients in whom we would extend therapy with apixaban, we would prevent one recurrent venous thromboembolic event. That's a huge impact on reducing the burden of recurrent thrombosis. Now the question is, what cost or price do we have to pay in terms of bleeding? Well, what's I think so striking about this study was that the apixaban regimens did not increase major bleeding relative to placebo treatment. And you see here the rates of major bleeding 0.2, 0.1, and 0.5 in a randomized double-blind trial. So we have pretty striking evidence for the first time that a regimen of extended therapy here was not increasing bleeding relative to placebo treatment, major bleeding, but was having a marked effect on reducing recurrent thrombosis. There was a rate of 2 to 4% here of non-major bleeding, other bleeding, which can be important to the patient. We shouldn't minimize this. It's still relevant, but in the scope of risk and benefit, we really, compared to what we could do with vitamin K antagonists, have shifted that balance, I think, much more in favor of an extended treatment for many more patients because of the impact with an acceptable risk. And so if we compare that to, say, then aspirin, and there were 2 trials of aspirin, aspirin also does produce risk reductions on the order of 20 to 40%. But if we look at the number needed to prevent one event, with the direct oral anticoagulants, we're talking 14 to 20 patients versus 22 to up to 59 with aspirin. Interestingly, contrary to what many clinicians would intuitively think, we don't have evidence that aspirin had a lower rate of major bleeding than the regimens of the new oral anticoagulants. Here we see a rate of 0.1 to 0.7 in the trials, compared with 0.5 to 0.6 in the aspirin trials. So there's no safety advantage of aspirin over the direct oral anticoagulants. There may be an expense advantage. It's likely the new oral anticoagulants are much more effective, as you've seen here. And there is a little bit higher rate of clinically relevant but not major bleeding. And perhaps further studies will help to refine the regimen to reduce that aspect. So when we then put this all together and say, how can we reduce the disease burden? We have a new tool. The direct oral anticoagulants are safer than vitamin K antagonists. We have to translate these findings into practice. We have to improve the earlier diagnosis of atrial fibrillation. And so as we go forward with World Thrombosis Day, our steering committee will begin to discuss how in parallel we begin to develop similar messages about atrial fibrillation. It's very easy to diagnose, check the patient's pulse or do an electrocardiogram, and we can find atrial fibrillation before the patient has a stroke, and we know that we can treat and prevent stroke very significantly. We must increase the use of primary prevention against venous thromboembolism in hospitalized patients in particular, and particularly in the right proportion of medical patients who comprise the biggest proportion of those suffering fatal pulmonary embolism. We want to reduce hospital-associated VTE, and the best way to do that is to do a risk assessment, and for health systems to adopt that patients admitted to hospital will have a risk assessment for venous thromboembolism, and then the physicians will decide on the appropriate prevention. Now that we have safer anticoagulation, we can be more confident to treat a greater proportion of patients for an extended or even indefinite time with a simpler treatment, which then will reduce the burden of recurrent venous thromboembolism. So primary prevention in hospitalized patients, better treatment that reduces recurrent events in patients who've had an event, those 2 things will go a long way to reduce the burden of venous thromboembolism. We must continue the new clinical trials along the lines of the Mariner study, which I presented, and other trials which are going to be addressing how we might refine our prevention and treatment strategies even further. And through World Thrombosis Day, we can increase global public awareness about these conditions, and especially about venous thromboembolism. And so I again want to congratulate all of you in the cooperative group here and in Argentina for your efforts. You've really been a model for how we should go about this. And join us again as we come toward October 13 to really get our messages out to the public, to know that hospitalization is a risk. Ask for a risk assessment. Talk to your doctor about thrombosis. Know that it's okay to engage in a discussion, and then to ensure that people get risk assessment and linked to appropriate prevention. It's been a real privilege to be here. I'm really excited by such a great audience on a Friday afternoon. When it's a beautiful day outside. Wonderful for me, maybe a little cold for you, but thank you so much for your interest, your dedication, commitment to doing this, and to all the efforts to really get us to understand and attack thrombosis as a major contributor to global disease. And I think that is working together with all our partners around the world, we're likely to see some real progress over the next 2 to 3 years. So thank you very much.